This video examines the role of iron therapy in patients with heart failure. Why is iron deficiency important in heart failure? It is a common comorbidity affecting 30 to 50% of chronic heart failure patients and up to 80% of those hospitalized with acute decompensated heart failure. Importantly, it can occur with or without anemia. Iron is essential for oxygen transport, muscle function, and energy production. Its deficiency leads to fatigue, shortness of breath, and reduced exercise capacity. These negative effects can occur even when hemoglobin levels remain within a normal range. Several factors cause iron deficiency in heart failure, including poor dietary intake, reduced absorption due to gut edema, and chronic inflammation, which increases hepcidin levels. Other contributors include chronic kidney disease and the use of certain medications like antiplatelets, anticoagulants, or proton pump inhibitor.
Iron deficiency is classified as either absolute or functional. Since ferritin levels can be falsely elevated by inflammation, clinical guidelines recommend using both ferritin and transferrin saturation, known as TSAT, to accurately diagnose iron deficiency.
According to ESC and ACC guidelines, iron deficiency is defined as having a ferritin level below 100 nanograms per milliliter, or a ferritin between 100 and 299 nanograms per milliliter combined with a TSAT below 20%. Patients often present with fatigue, exercise intolerance, dyspnea, and weakness. These symptoms can contribute to a poor functional class and frequent hospitalizations, regardless of whether the patient is anemic. Guidelines recommend screening for iron deficiency at the time of diagnosis, during follow-up, after hospitalization for heart failure, and whenever patients experience persistent symptoms despite receiving optimal therapy. Recommended investigations for iron deficiency include a complete blood count, serum ferritin, TSAT, serum iron, and TIBC. Providers may also consider checking renal function, CRP, and levels of B12 or folate if anemia is present. Oral iron often fails in heart failure patients due to poor intestinal absorption, high hepcidin levels, gastrointestinal side effects, and low compliance. Because of these challenges, intravenous iron is generally preferred. Ferric carboxymaltose is the preferred intravenous iron preparation due to its safety profile, ability to be administered in a large single dose, and strong clinical evidence supporting rapid replenishment in heart failure patients. Dosing for intravenous iron is based on weight, hemoglobin levels, and the calculated iron deficit. Typical doses range from 500 to 1,000 milligrams, though some patients may require 1,000 to 1,500 milligrams. Patient status should be reassessed after 12 weeks. Ongoing monitoring is essential. Reassess ferritin, TSAT, hemoglobin, symptoms, and functional class 3 to 6 months after the infusion. Repeat the treatment if iron deficiency recurs. The 2021 ESC guidelines explicitly recommend that all patients with heart failure be screened for iron deficiency using ferritin and TSAT. Intravenous ferric carboxymaltose carries a Class 1 recommendation to improve quality of life, symptoms, and exercise capacity in symptomatic patients. Additionally, it is a Class 2IA consideration following acute hospitalizations to help reduce the risk of readmission. Moving to the 2022 ACC, AHA, and HFSA guidelines, it is considered reasonable to screen all patients with heart failure with reduced ejection fraction. IV iron therapy has been shown to improve functional status, quality of life, and exercise capacity, and may help reduce hospitalizations. Notably, routine oral iron is not recommended. Regarding patient selection, those who benefit most are symptomatic patients with an LVEF of 40% or less, falling into NYHA Class 2 to IV, who meet iron deficiency criteria despite receiving guideline-directed medical therapy. The role of iron therapy in HF patients is still under study, and evidence currently remains insufficient for routine use. IV iron should be avoided in patients with active bacteremia, systemic infection, known hypersensitivity, or conditions of iron overload such as hemochromatosis. While adverse effects are generally uncommon, they can include headache, flushing, hypotension, nausea, infusion reactions, and in rare cases, anaphylaxis. Transient hypophosphatemia may also occur. To summarize, iron deficiency is common in heart failure even without anemia. Diagnosis requires measuring CBC, ferritin, and TSAT. For symptomatic HFrEF despite optimal therapy, IV ferric carboxymaltose is the preferred treatment. Reassess symptoms and iron status after 3 months, as routine oral iron is not recommended. Thank you for watching this overview of iron therapy in heart failure management.